Hello everyone, welcome back to my channel Dentistry Made Easy. The topic for today is posterior palatal seal area. So now, as the name says, it is sealing something. So this is the landmark when you're fabricating a maxillary complete denture. So as the name says, posterior, it means it is the area which is present posteriorly. Palatal is on the palate, and seal is because of this you get a proper seal, and your complete denture, it should be fabricated such that it should not be beyond this posterior palatal seal area if you want a good complete denture for a maxilla. So moving on towards this topic in depth. So what is the definition? It is defined as the soft tissues at or along the junction of the hard and soft palate on which the pressure within the physiological limits of the tissues can be applied by the denture to aid in the retention of the denture. So I'm going to break this into various parts. So the first is it is the soft tissue at or along the junction of the hard and the soft palate. So your PPS is a soft tissue that is at the junction. It is at the junction of the hard and the soft palate. So approximately it's over here. Then on which the pressure within the physiological limit of the tissues can be applied. Now you can apply the pressure on it and by the denture. So the denture, it applies the pressure on this area within the physiological limits so that you can aid in retention of the denture. So that retention is nothing but like your denture doesn't fall off during your movements, like functional movements when the person talks, eats or something. So at that time your denture shouldn't fall off. At that time you need a proper seal, and this is done by a posterior palatal seal area. So it is the area between the anterior and the posterior vibrating line. So now what is anterior and posterior vibrating line? I'm going to explain that. So over here, as you can see, this is a complete edentulous arch. So after that, we record the PPS. So this is the posterior most part. So it is like a limiting structure of your maxilla. So this is the posterior palatal seal area, and then you're fabricating a denture by which, like, this is the last part. So your denture shouldn't be beyond this posterior palatal seal area. So this is the definition which is given by Glossary of Prosthodontics. So what are the functions of it? It aids in the retention by maintaining a constant contact with the soft palate during functional movement like speech, mastication and deglutition, and thus it aids in confidence and comfort to the patient. So basically the main function of PPS is it aids in retention. So because of this, there is a constant contact between your denture and the soft tissue. So there is this contact during your functional movements like speech, mastication, whether the person talks, whether he's eating, then at the time of deglutition, there's this retention because of this PPS, and because of that, the patient is comfortable. It prevents air entry between the denture base and the soft palate. Now, as there is a constant contact, so there is a seal which is like produced. Because of that, it prevents air entry. The third one is it reduces the tendency for gag reflex, as it prevents the formation of the gap between the denture base and the soft palate during functional movement. So now the patient, he won't feel the feeling like a gag reflex because there's no gap between the denture and the soft palate, and your denture is not falling off again and again. Because of that, the patient, he won't feel gag reflex. Then the next is it establishes positive contact posteriorly, and therefore it prevents final impression material from sliding down into the pharynx. Now, when you're taking a final impression, you're taking a final impression with the help of eugenol, zinc oxide eugenol. So at that time, when you're taking impression, now you have like done, you have recorded your PPS properly, and because of that, there's a proper seal. And when and after that, when you're taking your final impression, because of that seal, it won't like the final impression won't slide into the pharynx. The next it prevents food accumulation fluid between the posterior border of the denture and the soft palate, as there's no gap again. And lastly, it compensates for the polymerization shrinkage of the methyl metaacrylate resin. So that is your monomer. So it like compensate for the polymerization shrinkage. So when you're fabricating a denture, there's this shrinkage. When you're polymerizing it, there's a shrinkage of your monomer. So it prevents, it compensates for that. So these are the functions of your PPS, and this is like the most important part for your maxillary complete denture. If you want a good maxillary denture, then your PPS, it should be recorded too good, so that the patient won't come back saying my denture is falling off, or I'm having pain, or like any other problems, because your PPS only will give these problems to the patient. Like the denture, if it is falling off, it is because there are errors when you're recording your PPS. So make it a point that whenever you're recording your PPS, it should be like the best PPS you're recording it. The next is, it has two parts, like it is divided into two regions, pterygomaxillary seal and postpalatal seal. So your pterygomaxillary seal is this area and postpalatal seal is this. And these two, it forms your posterior palatal seal area. Then what is pterygomaxillary seal? It is a part of PPS. It extends across the hamular notch and it extends 3 to 4 mm anterolaterally to the end in the mucogingival junction on the posterior part of the maxillary ridge. So now what is hamular notch? Hamular notch is nothing but it is a depression which is situated between the maxillary tuberosity. So this is like the depression over here. So these are your maxillary tuberosity. So this elevated bony part. So this is your maxillary tuberosity. So behind that there's a depression which is your hamular notch. So pterygomaxillary is the part of PPS. Extends it extends across the hamular notch. So it is extending from the hamular notch and it is extending 3 to 4 mm anterolaterally, that is anteriorly and laterally. So this is medially. So it is like extending in front anteriorly and laterally to the end in the mucogingival junction. So it is like extending to the end of the mucogingival junction. So this is your pterygomaxillary seal. So your hamular notch is located between the maxillary tuberosity. It contains your pterygomaxillary seal. It contains loose connective tissue and few fibers of tensor villi palatini muscles. So this is what exactly it contains. And the position of this membrane, it changes with the mouth opening. Hence, it should be recorded accurately during impression making. So like if you're extending your denture beyond this hamular notch, then the patient will come up with severe pain whenever he's wearing the denture. So make it a point that you're not extending your denture beyond this hamular notch area, beyond this PPS area. The next is the postpalatal seal. Postpalatal seal, it is a part of the posterior palatal seal. It extends between the two maxillary tuberosities. So this is the part, and this is the postpalatal seal, and it extends between two maxillary tuberosity. These are your two maxillary tuberosity. It is between that. That is your postpalatal seal. So because of this, you form a PPS, that is posterior palatal seal area. So now what is vibrating lines? Vibrating line, it is defined as, it is an imaginary line across the posterior part of the palate, making the division between the movable and the immovable tissues of the soft tissues, which can be identified when the movable tissues are moving. So basically it's like you're drawing an imaginary line across the posterior part. So you're drawing this imaginary line across the posterior part of the palate. So you're drawing this on the posterior part of the palate, and you're dividing, like basically you're dividing the movable and the immovable tissues of the soft palate. So there are like the soft palate, it has two parts, like slightly movable tissues and like movable, properly definitely movable tissues. So you're dividing these two by this vibrating line. It is the imaginary line which is drawn across the palate that marks the beginning of the motion in the soft palate, but the individual say ah. So you ask the patient to say ah. At that time, this is the imaginary line that is drawn on the palate. So it extends from one hamular notch to the other. It extends from one hamular notch to the other. It should lie on the soft palate. So here this vibrating line, it should lie on the soft palate. And there are two imaginary lines. So these vibrating line, that is the anterior vibrating line and posterior vibrating line. So anterior vibrating line is It is an imaginary line that is lying at the junction between the immovable tissues over the hard palate and slightly movable tissues of the soft palate. So starting off with like the vibrating line. So this is your hard palate and this is the soft palate. So hard palate is present anteriorly and soft is present posteriorly. So at the end of your hard palate, so your hard palate is immovable. So it is the imaginary line which is lying at the junction between the immovable tissues of the hard palate. So it's over here, and slightly movable tissues of the soft palate. So these, like the front portion of your soft palate is slightly movable, and the back portion over here, it is like definitely it's like more movable. So anterior vibrating line, it is a junction between your immovable hard palate tissues over the hard palate and slightly movable tissues of the soft palate. And it can be located by asking the patient to perform the Valsalva maneuver. So Valsalva maneuver is like you're asking the patient to hold the nostril firmly, and after that you ask the patient to blow through the nose gently. So it's like the patient is asked to close the nostril firmly and he is gently blowing through the nose. And that time you'll see this anterior vibrating line. And this anterior vibrating line is a cupid bow shape. So it's like this. It's a cupid bow shape. And it is cupid bow shape because it is like the cupid bow shape is because it follows the posterior nasal spine and the posterior part of the hard palate. And Valsalva maneuver, when you're asking the patient to do Valsalva maneuver, so basically what it does, it positions the soft palate inferiorly at the junction with the hard palate. And cupid bow, so over here, as I said, this is a cupid bow shape. So cupid bow shape is because it follows this projection of the posterior nasal spine. So this is the pointed. So over here, this is pointed portion is your posterior nasal spine. So as you can see on this maxilla, on this skull, so there's this cupid bow shape. So the anterior vibrating line, it follows the same, and hence it is a cupid bow shape. The posterior vibrating line is an imaginary line which is located at the junction of the soft palate that shows limited movable and soft palate that shows marked movement. So it is like the junction between the slightly movable and movable parts of your soft palate. And it is recorded by asking the patient to do A in short but normal non-vigorous fashion. And the line is usually straight. So this portion is your posterior vibrating line. So this is a posterior vibrating line. It is usually straight, and anterior vibrating line, it is a cupid bow shape. So this forms your PPS. Now how do you record it? So this is the, like we have seen what all do we, like what all we are required to write in an answer, but now clinically how you're going to record it. So these are the like points that you can write in your exams too, but you should know how to record it properly. So there's this classification of PPS. So it is divided into three classes. So class 1 is butterfly shaped, class 2 is arc shaped, class 3 is narrow band. So butterfly shape is basically the normal one that you see over here. So this is a butterfly shaped. Arc shaped is here the PPS is widest in the mid palatine raphe. So over here, this is your mid palatine raphe. So it is widest in the mid palatine raphe, and that is like you won't find a depression, a depression over here. Instead, it will be like this, arc shape. And class 3 is a narrow band. That means it's like a narrow band, a thin band. So that is your class 3. So the now when you're recording your PPS, so there's this three things you need to see: the size, shape, and like everything, dimensions of your PPS. So the anterior posterior width of the PPS, it is 8 mm at the widest point. Then the average interhamular notch distance is 37.1 mm in males and 35.6 mm in females. So this is like a value which was given by Silverman when he actually conducted, like when he actually recorded PPS on more than like around 80 to 90 patients he did, and this was the average value that came out. And so this is like the anterior posterior width of the PPS is 8 mm. So basically your PPS is 8 mm. Then the distance between the hamular notches, It is 37.1 mm in males and 35.6 mm in females. And the average distance between the anterior vibrating line and fovea palatini is 1.31 mm. So what is like fovea palatini? Fovea palatini is nothing but it's like over here, as you can see, this dotted portion. So it is like it is present in front of your anterior vibrating line. So over here, fovea palatini is this. So these are like two glandular opening within the tissues of the posterior portion of the hard palate, which is usually lying on the either side of the midline. This is your midline, it is lying on the either side of it. They are the ductal opening into which the ducts of other palatal mucosal gland they drain. And it does not represent the junction of the hard and soft palate. And it should not be used as a guidance to like for the placement of a PPS. So this is like a fovea palatine which is present like in front of anterior vibrating line, and the distance between it is 1.31 mm average. So like there are various methods to record PPS. So there were like conventional approach, fluid wax, arbitrary scraping, and extended palatal technique. So extended palatal technique is not accepted now because what it actually does is Silverman he proposed that the posterior border of the denture it can be extended by 8 mm, but this is not done right now. So the approach which we are using is the conventional approach, and I'm going to explain like how exactly you need to do it. So there are like few points that you should remember when you're recording the posterior palatal seal. The posterior border of the denture it should not be placed over the mid-palatine raphe or the posterior nasal spine. So your mid-palatine raphe, as you know, it is like leaf structure of your maxilla. Then it should not be over it when you're recording PPS. So your PPS should not be over mid-palatine raphe. Then if there is palatine torus which is present posteriorly, which can interfere with your posterior palatal seal, that time that tori it should be removed. The position of the fovea palatini it also influences the position of the posterior border of the denture. The denture it can extend 1 to 2 mm across the fovea palatini. Then like these are like some points that you should remember when you're making a good PPS, when you're recording PPS. So these are the points that you should remember. So starting off with the conventional approach, so I'm going to explain like exactly what conventional approach is. Starting off with the conventional approach, first point is the patient is asked to sit in an upright position and is asked to rinse the mouth. So after that, the posterior palatal. So after that, you're wiping off the posterior palatal area with a gauze because there's the presence of saliva. And as you're marking it with a pencil, and if there's the presence of saliva on that wet surface, you cannot use your pencil properly. So you need a dry area. So you need to dry it properly. So you're wiping it with a gauze. Then you're using a T-burnisher. So this is T-burnisher. T-burnisher. So the T-burnisher it is used to locate the hamular notch by palpating posteriorly to the maxillary tuberosity on the both sides. The full extent of the hamular notch it is marked with a pencil. So first you're using this T-burnisher and the hamular notch is palpated. Then the posterior vibrating line is marked using a pencil by asking the patient to say ah in non-vigorous manner. After that, first you palpated your hamular notch with a T-burnisher, then you're marking your hamular notch, and after that you're like recording the posterior vibrating line. Your posterior vibrating line is marked between the movable and immovable soft palate. So it is like slightly movable and marked movement soft palate. So you're marking it when you're asking the patient to do ah. So the patient he says ah like non-vigorously, and at that time you'll mark this. So you'll see a line, proper line. When he's saying ah, you'll see a proper line, and then you're marking it with the pencil. The line it is marked in the hamular notch is connected with the posterior vibrating line using a pencil, and this will form the posterior border of the denture. So now you have marked your hamular notches, and then you have even marked your posterior vibrating line. Then you're going to join it. So the hamular notch and the posterior vibrating line they are joined using a pencil. So now you have joined your these two lines, and this forms the posterior border of the denture. So your denture, it should not be beyond this border. So it should end over here. And then the trial base, so your denture base is inserted into the patient's mouth so that the markings, they are transferred to the trial base. The markings on the trial base can be refined if necessary. And then the trial base is trimmed till the posterior border. Then you are marking the anterior vibrating line by the Valsalva maneuver, and I have explained what exactly a Valsalva maneuver is. And then you'll see a cupid bow shape over there, and this is the marking of your PPS. The area between the anterior and the posterior vibrating line is scraped in the master cast to a depth of 1 to 1.5 mm on either side of the mid-palatine raphe in the region of the mid-palatine raphe, and it should be only 0.5 to 1 mm in depth. And the posterior border of the posterior palatal seal should be tapered so that it blends with the palatal tissue, and this entire border of the postdam, it resembles the shape of the cupid bow. So basically, so you have marked it, then you transfer it on your record basis, and when you're and then after that, you're like this marking, they are scraped off on the master cast. And this was the conventional approach. And after that, the last part is like you'll see errors, obviously. Like there are errors when we are recording posterior palatal if we are not doing it properly. So there can be errors, like there can be under extension or over extension. Under extension, because of under extension or over extension, your denture is not stable, it is not retentive. And under extension, it is the most common cause of poor posterior palatal seal. So there can be many reasons because of which under extension can be caused. So it can be like you have excessively trimmed it. When you're trimming your posterior border by mistake, you have excessively trimmed it. And there can be like if the patient is having gag reflex, so because of that fear, you're not like marking it properly. So many reasons can have this under extension. Overextension is overextension, it can lead to ulcerations of the soft palate, and it can lead to painful deglutition. If there is covering of the hamular notch, it can lead to sharp pain in that region. And in order to relieve this area, pencil markings are made on them and they're transferred on the denture. And after that, if it is overextended, then you can easily trim it and polish it. And if there is under extension, then you can do relining or rebasing. Like there are many things that you can do if there is under extension. And if there is overextension, so it is like way too easy, you can just trim the extra portion. So these are the errors which you can see. But now again, if you are recording it properly, then you won't like face this errors when you're recording a posterior part. That was it of this video. I hope you found this video helpful. Thank you so much.